Okay, let's talk a little bit about hemodynamics. So these are things that are going to affect blood pressure. So as we talked already about cardiac output, blood volume, viscosity, resistance, and then the elasticity of arteries. So all of these things are going to affect our blood pressure. And to me, the easiest way to talk about all of these is if we, instead of individually, but let's just take a look at them in totality and how they all influence one another. A flow chart really, to me, is the best way to do this. And maybe we can do the things that we're already familiar with. So, okay, let's start actually down at the bottom. So this is our mean arterial pressure, or we can think of that as simply as blood pressure. And we've already talked about cardiac output. So let's just kind of reverse engineer this. We know cardiac output is heart rate times stroke volume. So if we increase either one of these two things, we will increase our cardiac output and we'll increase our mean arterial pressure, Okay, well, how do we increase our stroke volume? Well, through more sympathetic impulses, hormones such as, again, norepinephrine, epinephrine, will increase our stroke volume. If we have more blood returning to the heart, that's also going to increase our stroke volume. If we decrease our sympathetic nervous system, all of that will increase our heart rate as well. So decrease sympathetic or decrease parasympathetic, increase sympathetic, increase our heart rate, increases our stroke volume, increases our cardiac output, increases our mean arterial pressure. So how do we increase the venous return? Through vasoconstriction, so constriction of our veins, that respiratory pump that we talked about, skeletal muscle pump. So these are those three things that we talked about earlier, helping move blood back up toward the heart, as well as increasing our blood volume. If we increase our blood volume, we'll increase the amount that can return, which will increase our stroke volume, which will increase our cardiac output, which will increase our mean arterial pressure. So really, all this in green we've already talked about. Now on this side, if we increase our vascular resistance, that will also increase blood pressure. So what are some of the things that increases this? Well, blood viscosity. If our blood becomes more viscous, for example, if you have too many red blood cells, that'll increase blood viscosity. That will increase vascular resistance. It will increase our blood pressure. Now that is not necessarily a good thing, right? If we have more blood vessels, total blood vessel length, for example, due to an increase in body size, for example, due to obesity, that will increase the number of blood vessels in length. That will increase the vascular resistance. That will increase blood pressure. That's one of the reasons why when people have high blood pressure, one of the first things they look at is seeing if they can reduce some of their weight, because it'll decrease the blood vessel length, which will decrease the overall resistance, which will decrease blood pressure. And then the decrease in blood vessel radius, so vasoconstriction, will also cause an increase in resistance, which will increase blood pressure. So on this side, the green side, this is really things that can occur normally, like just simply due to sympathetic stimulation, again, just due to an increase in activity or decrease in activity. These are more things that are, I would say, a little bit more dangerous, I guess, or less healthy. Maybe the one that is sort of the outlier here is this decreased blood vessel radius that can happen just, again, normally, to help increase vascular resistance over, a short period of time. But again, all of these things will either increase, or if we look at these just the opposite, if we say we decrease this, decrease, that will decrease blood pressure, right? So hopefully that makes sense to you. So all of these different things that we talked about, the cardiac output as well as this resistance, all of that will affect your blood pressure. Okay, if we take a look at what it looks like in our blood vessels, so let's take a look at this top graph. So here's our aorta, arteries, arterioles, capillaries, venules, veins, and then the vena cava. Again, that's right before we go back to the heart. And then here on the y-axis, we have pressure in millimeters of mercury. So not surprisingly, as we are in the arteries, arterioles, and the aorta area, there's fairly high blood pressure, and this rise and fall correlates to the pumping of the blood. So every single time ventricles contract, we have the systolic blood pressure, and when they relax, we have the diastolic pressure. Right? And then as we get further and further away, the blood pressure is going to decrease until we have very low blood pressure in the veins and in the vena cava. Now, this bottom graph is actually looking at the speed of blood flow and the cross-sectional area of the blood vessels. So again, we have aorta, arteries, arterioles, capillaries, venules, veins, vena cava. This green line is a cross-sectional area. The larger this number, that means the more cross-sectional area there is in total. So even though these capillaries are very tiny, there's so many of them that if we add them all up, there's greater cross-sectional area than the aorta. And then what we'll see here, again, with velocity here in black, every time the ventricles contract, there's an increase in speed, then a decrease in speed as blood flows to the body. Increase, decrease, increase, decrease, increase, decrease. And as we're seeing, as that cross-sectional area goes up, it actually starts flowing a lot slower. That's one of the reasons why we have the gas and nutrient exchange occurring in capillaries, because it's slow enough to actually happen. Okay, and then as we get back, as a cross-sectional area decreases, velocity picks back up again. Okay, so we talked a little bit about this. So things that control blood pressure and blood flow. So we have that cardiovascular center in the medulla. We have something called baroreceptors and chemoreceptors. We'll talk a little bit more about them in a slide. Hormones, and then just simply local regulation. So that cardiovascular center in the medulla helps regulate heart rate and stroke volume. We saw that in an earlier lecture. There are specific neurons that are going to help regulate blood vessel diameter. And there's input from other higher brain regions. We talked about the cerebral cortex, the limbic system, again, the emotional part of the brain, the hypothalamus, as well as the proprioceptors. These are those receptors that are monitoring movement in your body as well as location. And then baroreceptors and chemoreceptors. And again, we'll talk about those more in another slide or so. And then output to the heart will either decrease or increase the rate and contractility. Again, a decrease is part of the parasympathetic nervous system, and an increase is going to be sympathetic nervous system. And then the output to the blood vessels may be vasoconstriction, which would be sympathetic, and then vasodilation would be parasympathetic. Now, baroreceptors, and you can see there's one here right in the neck, in the carotid artery, as well as the arch of the aorta. These are receptors that are sensitive to changes in pressure. That's what a baroreceptor is. Kind of like a barometric barometer is sensitive to barometric pressure changes. A baroreceptor in the body is also sensitive to changes in pressure. So the carotid sinus reflex, this is going to be in the internal carotid artery. And basically what it's doing is it's monitoring the blood flow to the brain. That's because really, really important, right? Whereas the ones in the aorta are monitoring and maintaining general systemic blood pressure. I mean, those two are perfectly located at these crossroads that can monitor either flow to the brain or to the body. Is it flowing enough? Do we have enough pressure? Do we need to increase it or decrease it? Now the chemoreceptors, as their name kind of implies, chemo, the chemical, that the chemicals specifically that they are going to be monitoring for are levels of oxygen, carbon dioxide, and hydrogen ions. So lack of oxygen, too much carbon dioxide, that's hypercapnia, or acidosis, too high levels of hydrogen ions. And these are actually right next to those baroreceptors, just sort of side by side. So you see there's carotid bodies and aortic bodies. And depending on what they pick up, they can cause a stimulation of the cardiovascular center of the medulla. So again, if they're finding that there's too much carbon dioxide, not enough oxygen, very high levels of hydrogen ions, they can send signals to the brain saying, okay, we have to increase our heart rate, our breathing rate, all of that. And again, right now in this section, we're talking mostly about heart rate and blood pressure, but really a lot of this will also involve our breathing rate too. They will also increase the sympathetic stimulation to arterioles and veins, which will then cause vasoconstriction and an increase in blood pressure. Okay. The hormonal regulation, the big ones are something called the renin-angiotensin-aldosterone system. Now I want you to really put a pin in this one. This one's going to come back quite a bit when we talk about the urinary system. But basically a decrease in blood pressure or a decrease in the blood flow to the kidneys will cause them to release something called renin. There's a sort of a multi-step process, but ultimately it results in the formation of something called angiotensin II. That angiotensin II causes vasoconstriction. So think of it like I think angiogram is basically like a chart of blood vessels. And anytime you see angio, it's referring to blood vessels. And then think like tensin, like when you tense up, you like constrict. So blood vessel constrictor number 2. So it causes systemic vasoconstriction, and it will also cause the release of aldosterone. And what aldosterone does is it causes the absorption of salt as well as water. And every time you absorb water, you're going to increase your blood volume, and increasing your blood volume will increase your blood pressure. Okay. Epinephrine and norepinephrine, we've talked a bit about it already. So it increases our heart rate as well as the contractions. It can also cause vasoconstriction in the skin and abdominal organs. Again, it's preferentially going to send blood to our muscles. So there's going to be vasodilation in the cardiac muscles as well as skeletal muscles. As the heart has to work faster, it also needs more oxygen and nutrients itself. So that's epinephrine, norepinephrine. There's another hormone called antidiuretic hormone. Another name for that is vasopressin. It also causes vasoconstriction, plus it also will cause the reabsorption of water. So again, all of that increasing our blood pressure. So remember, vasoconstriction is going to increase resistance, which will increase mean arterial pressure. And then again, as we reabsorb more water, as we reabsorb more water, we're going to increase our blood volume, which will increase our blood pressure. So all these first 3 are there to help increase our blood pressure. Atrial natriuretic peptide is the one that is a little bit different than these others. It is there to help lower blood pressure. So instead of causing vasoconstriction, it does the exact opposite. It causes vasodilation. So again, that would decrease resistance in the blood vessels, therefore decreasing mean arterial pressure. And it also allows for sodium to be lost in urine, and wherever salt goes, water follows. So as we lose more salt, we will lose more water in our urine. That means we are not retaining water as much, which means we're going to decrease our blood volume, which means we will decrease our blood pressure. And then the local regulation of blood pressure is called autoregulation. So it's the ability of tissue to adjust its own blood flow to match its metabolic demand. So for example, let's say you're really, hammering away at something with your right hand. Your left hand is not really doing anything. Your left arm's not doing anything. You're going to have autoregulation, and you'll see vasodilation occurring in the muscles of the right arm compared to the left arm, compared to like your legs, especially if you can see you're just sitting there. So all of that to bring blood to that body part, right? Especially when the others are not active. Okay, and those are things, these are local factors that will cause these changes. So temperature, obviously the muscle that is active is going to have a higher temperature. Potassium buildup, hydrogen ion buildup, this will be due to carbon dioxide production, lactic acid buildup, nitric oxide buildup. So nitric oxide will act as a vasodilator, as well as oxygen levels. Okay, so all of those will factor into like what allows more blood to flow to a specific body part, especially when the others are not equally active. Okay, so how do we check blood pressure? Well, all right, so two things. One, you may have heard of measuring someone's pulse. So that's simply a pressure wave, so you actually feel that wave every time your heart contracts. And usually we'll have like different areas, so up by the neck is the usual spot, down by the radius. Sometimes you may check someone's femoral artery or even at the top of their foot, especially if there's been some sort of an accident or injury. You want to make sure that you can still feel the pulse pressures in the extremity. That indicates that that blood vessel has not been severed in some way. And your pulse rate is normally somewhere resting 70 to 80 beats per minute. Some athletes may have that lower than others. And here's some definitions for you. Tachycardia is defined as over 100 beats per minute, and then bradycardia is under 60 beats per minute. And then you are familiar with your blood pressure cuff, the sphygmomanometer. What you're doing, so the way this basically works, you use a stethoscope along with a blood pressure cuff. And what you're doing is there's this brachial artery, right, main artery in the arm, and the blood pressure cuff, as you know, tightens over it. And what it's doing is it actually squeezes off that artery, so blood cannot flow through. So, and what you do is you slowly let the air out of the blood pressure cuff, and at some point the pressure in the cuff is equal to the pressure here in the blood vessels, so that blood can finally start flowing through again. And when it does that, you actually hear turbulence, and that's what is called a Korotkoff sound. So when you start hearing it, that's what people use a stethoscope. That first sound you hear indicates that your systemic blood pressure is equal to whatever the pressure is in the cuff. So that's your systolic pressure. And then at some point, the blood pressure in the cuff is so low that it's no longer obstructing the flow of blood at all, so you stop hearing sounds. You don't hear the turbulence anymore, and that's indicative of the diastolic pressure. Okay. And then pulse pressure is simply the difference between your systolic and diastolic, so you would subtract the diastolic from the systolic. And the normal ratio is 3 to 2 to 1, systolic diastolic pulse pressure.